All right. I'm mindful it's late in the day and I'm the last presentation and might not be one of the save the best for last type scenarios, but appreciate y'all bearing with me here. So my name is Bill Kromka. I'm one of the psychiatrists here at Boulder Community Health. My position here has several different roles in the outpatient department, and the inpatient unit, but also in the Center for Interventional Psychiatry. So I today kind of chose to highlight the IV ketamine treatments and just ketamine in general. Over the past 2 decades, it's become a much more commonly encountered ketamine and ketamine treatments, much more commonly encountered in the community and in the media, for better, for worse. So figured could give a kind of broad strokes overview of ketamine in general and what it is, its role in psychiatric treatment, and then kind of finish with some BCH specific items related to that. So again, just kind of a general outline of things. We'll start with just a brief kind of history and timeline of where ketamine even comes from and how it emerged as a common place treatment in psychiatry, and delve a little bit into pharmacology, medical science, and talk about what it looks like clinically and what treatment looks like, and then finish with kind of BCH specific information. So ketamine was essentially the third drug created in a class of compounds known as aryl cyclohexylamines, but more commonly known as dissociative anesthetics. These were first created by the pharmaceutical company Parke-Davis, now a subsidiary of Pfizer, with the intent of finding novel anesthetic agents. The first drug in this class of compounds was actually PCP. And you can imagine using PCP for anesthesia went about as well as you could imagine it went. And so they continued the search for better tolerated and safer anesthetic agents, which ultimately led to the creation of ketamine in 1962 by the chemist here, Calvin Stevens. And then after several years of trials, it was ultimately approved by the FDA in 1970 for anesthesia. And then from 1970 onward, ketamine was almost exclusively used for anesthesia and pain management, but it was also around this same time in the early 1970s that some of the first publications emerged of ketamine being used in a psychotherapeutic context. And it was indeed used by practitioners in different parts around the world as a kind of psychedelic adjunct to psychotherapy over the past 50 years. Albeit to a much lesser degree than the past 20 years more recently. So fast forward through all that, in 1999, the DEA ended up classifying ketamine as a Schedule III drug due to abuse potential. But shortly thereafter, just 1 year later, in 2000, came the first double-blind, placebo-controlled, randomized controlled trial of IV ketamine for the treatment of major depressive disorder, published in Biological Psychiatry. And that heralded a kind of proliferation of studies and research examining ketamine, primarily intravenous ketamine, as a treatment for depression and other psychiatric indications. Which particularly skyrocketed around 2010, moving onward. And then only recently, in 2019, was when the FDA ended up approving intranasal Esketamine, which I'll distinguish from ketamine here in a moment, for treatment-resistant depression in combination with an oral antidepressant. And then 1 year later, updated that to also include the indication to be depressive symptoms in adults with major depressive disorder and acute suicidal ideation or behavior. And we will talk more about all of that. So just a good starting point for just kind of understanding ketamine in general in this conversation is the pharmacology. So ketamine is a mixture of 2 mirror image molecules, R and S ketamine, and the isolated S enantiomer is also called Esketamine, was isolated and branded by Janssen Pharmaceuticals as Spravato. So that is distinct from ketamine, which when I refer to ketamine going forward is the mixture of both the R and the S, but there also exists now the Esketamine, also known as Spravato. Again, they're in this class of compounds that you'll hear as dissociative anesthetics, and their primary site of action is at the N-methyl D-aspartate receptor, the NMDA receptor. And they serve as antagonists, meaning they block that receptor on the neurons in our brain. I'll circle back to that a bit later in discussing how ketamine works as an antidepressant treatment. But just to note, there are also many other receptor interactions in our brain and body that ketamine and esketamine act on, including the serotonin and norepinephrine transporters, and dopamine, opioid, cannabinoid receptors, and many others. And this slide here is just to highlight that ketamine is available in many different formulations. For its use in psychiatric indications, intravenous is the most common, but there's also intramuscular, subcutaneous, intranasal, and oral. Whereas the branded esketamine, Spravato, is only available in the proprietary intranasal formulation, at least here in the US. So now that we've kind of covered what ketamine and esketamine are generally and how they're available, can begin discussing a bit more about kind of their uses in mental health and the clinical side of things. So started here with this quote from a study in the American Journal of Psychiatry synthesizing the evidence of ketamine and esketamine in depression. And it reads, replicated, short-term, randomized controlled studies have unequivocally established the rapid and significant efficacy of both intranasal esketamine and intravenous ketamine in adults with treatment-resistant depression. And treatment-resistant depression is commonly defined as non-response to 2 or more antidepressant medication trials of adequate duration, so around that 4 to 6 week period. And so that highlights a few points here. One, mentioning the rapid effects. So the antidepressant responses are rapid and they can be noted within 40 to 120 minutes, but are generally short-term, as the responses from a single dose last anywhere from a few days to up to 2 weeks. And so that has bearing on kind of the treatment course and how we provide ketamine in both an acute and maintenance fashion, which I will end up closing with a bit later. And so esketamine, or Spravato, is limited to use in its FDA-approved indications. And Spravato is FDA approved for the use in adults with treatment-resistant depression, as per that definition, or depressive symptoms in adults with major depressive disorder with acute suicidal ideation or behavior. Whereas ketamine is used off-label in psychiatry and is almost exclusively paid for out of pocket, so it can be considered for a wider range of patients and indications as compared to esketamine or Spravato, which is much more tightly monitored and controlled through a risk monitoring REMS system. And so ketamine, there's evidence for its use in these other conditions, PTSD, OCD, substance use disorders, bipolar spectrum disorders. It is important to note, though, that the evidence supporting ketamine's use in these other conditions beyond unipolar, treatment-resistant depression is not nearly as robust as the evidence that supports its use in unipolar treatment-resistant depression. So for the intents and purposes of this talk, I'll be referring to ketamine and esketamine primarily as antidepressant treatments. And so how is it thought that ketamine and esketamine accomplish this antidepressant response in these therapeutic outcomes? And the contemporary framework for answering this question is generally been driven by a biochemical or biological paradigm that attributes the therapeutic and antidepressant responses solely to ketamine's pharmacologic actions and its kind of neurobiology, independent of any of the acute psychoactive effects or subjective phenomena or other supporting interventions. The reality is almost certainly that ketamine's antidepressant effects involve both, the biological and neurobiological mechanisms, as well as psychological and subjective aspects. And so from the biological perspective, ketamine's antidepressant effects are primarily attributed to its action at that NMDA receptor I mentioned. Ignore that way too busy and too small graphic there to the left. That's kind of an abridged version of this receptor interaction, but what's important to highlight is kind of the downstream results of that being noted to be synaptogenesis, the process of making connections between neurons, and synaptic potentiation, which is the process of strengthening those neuron connections. But overall, the biological mechanisms underlying ketamine's antidepressant effects are still being studied and are considered incompletely understood. And there's a range of other mechanisms that are implicated, listed here being some changes in functional connectivity of certain neural networks, anti-inflammatory properties, and actions within dopamine, serotonin, and opioid systems. And in addition to the biological aspects here, there's growing evidence and understanding that the acute psychoactive effects and the subjective experiences, particularly the subjective psychological experiences of ketamine, including the psychedelic properties, play an important role in mediating the antidepressant outcomes and some of the other therapeutic benefits. And so these acute psychoactive effects of ketamine do share many parallels with some of the classic psychedelics, and they can encompass quite a range of different subjective experiences, which I'll kind of briefly highlight and turn to now. So in this component, as with the effects of other psychedelic substances, the subjective experiences of ketamine are highly dependent upon the dose and the now cliche duo of set and setting, which in this context, set referring to the mindset, preparation, intentions of the individual receiving the ketamine, and the setting being more of the physical space environment, the social and cultural environment in which that treatment is being given. And so, although this is not an exhaustive list here, the main phenomenological themes that have been noted in research and reports of the subjective experiences of ketamine include kind of the range listed here, these perceptual changes with distortions in time, space, and body, dissociative experiences, potential for anxiety, yet also on the other hand, reductions in vigilance or physical vigilance, cultivating empathogenic states, softening of ego defenses, and then as you move to the right here with the higher doses, some more of the robust psychedelic experiences of these out-of-body experiences, mystical type experiences, ego dissolving, transcendental experiences, all quite the mouthful, but and hard to really imagine what that's like. And even though these ketamine experiences are generally dose dependent, with these more robust psychedelic experiences occurring at the higher dose ranges, there are many reports and indications that some of these psychedelic phenomena, such as the mystical type experiences, out-of-body experiences, do occur with lower doses of ketamine, and so the relationship is certainly not as linear as the graphic here makes it appear. And as could be imagined, with all of these taken together, many of these properties have the potential to catalyze significant positive change in mood and cognition, and they can serve as powerful means for reshaping and resituating, rethinking previously long-standing, rigidly held negative beliefs about oneself and the world, and offer significant therapeutic benefit there. And even though the dominant mode of ketamine use in research and clinical settings is still primarily solely just as a pharmacologic agent, there is a long-standing tradition for and growing evidence base supporting ketamine-assisted psychotherapy, abbreviated CAP. And so CAP is a model in which the subjective psychoactive effects of the ketamine are leveraged to enhance a paired short course of psychotherapy. And this is something that is not always offered, but is certainly out there in the community. But regardless of whether the ketamine is being provided with or without the paired psychotherapy, we can move on to discuss and take a closer look at some of the more practical, like clinical aspects of ketamine treatment. So I'm just going to pull all of these up here. And so the first branch point of whether ketamine should be considered for psychiatric treatment begins with age. And so Spravato, or Esketamine, is FDA approved only for individuals 18 years of age or older. And ketamine, distinct from Spravato and Esketamine. So ketamine has been studied in pediatric patients with some evidence supporting its efficacy in adolescents 13 to 17 years old, but these studies are limited in both their numbers and their strength, and so at this time it really should only be considered, for pediatric patients in very select cases. And as was briefly touched on earlier, both ketamine and esketamine have ample evidence supporting their efficacy and use in the treatment of patients with treatment-resistant depression. And although, as I mentioned, there is evidence for the use of ketamine in these other conditions such as PTSD, bipolar depression, substance use disorders, OCD, because it's not as robust as the evidence in depression. I listed it here with some of the other medical conditions and situations in which we just a bit more carefully consider the patient for ketamine treatment. By no means, exclusion or contraindication, but just things in which we want to give a bit more pause. And then in red down here, the contraindications listed in red are those provided directly from Esketamine or Spravato's full prescribing information packet. So a hypersensitivity or allergy to ketamine or esketamine, aneurysms, arteriovenous malformations, history of a brain bleed, the intracerebral hemorrhage. A lot of these contraindications are anchored on the cardiovascular risk factors, as ketamine can increase blood pressure and heart rate while you're receiving it. I do want to note here that there are obviously other risks to be discussed with ketamine and esketamine, and that we certainly review in depth when discussing it with patients. But for the intents and sake of brevity for this conversation here, we'll be just acknowledging those, but not going into that in too much depth. And so after having considered the appropriate patient selection in terms of risks and benefits, and now comes a consideration of where ketamine treatment falls in the treatment algorithm. And one way to conceptualize this decision-making process is just thinking of whether somebody falls in one of two broad categories of an interventional treatment or adjunctive medications. And the interventional side of things, ECT, TMS, ketamine, versus are we considering ketamine, esketamine, or alternative or additional medication adjustments. There are very few studies comparing ketamine or esketamine head-to-head to other adjunctive medications in depression. So the decision should essentially just entail consideration of a range of different variables, like the illness severity, the patient preference, clinical infrastructure and availability, cost, and amongst other things there. And there is a bit more data, including several recent studies that help to provide some direction in choosing between ketamine, esketamine versus ECT or TMS. But the details of that decision-making process, without getting too much into the weeds of data and trials, are kind of beyond the scope and time of the presentation, so we'll leave it at the basic takeaway that essentially choosing treatment modalities in depression involves considering a lot of different factors, variables, and options, and there's never one exclusive right or wrong answer or like, last end resort. But if we have gotten to the point where we're just, deciding to pursue, ketamine treatment, kind of begs this question of, well, there is this esketamine or Spravato, and they are distinct entities, yet very, very similar. So what's the difference? How do we choose? Is one better than the other? There are limited trials comparing ketamine and esketamine head-to-head. And again, without getting too much into the weeds of the data and the trials, the bottom line is that ketamine might be more effective than esketamine, but there's no, unequivocal, solid evidence one way or the other to say for certain. And so ultimately the decision will come down to consideration of some of those same variables, three primary ones here. As always, in the mixed patient preference, if somebody has had a friend or family member that has had a positive experience with one versus the other, that's something to take into consideration. Just clinical infrastructure, like for example at BCH, as I'll touch on in a bit, at the current time, the Center for Interventional Psychiatry just offers the IV ketamine treatment, and so perhaps in the future there will be esketamine offered as well, but if that's going to, that could be a factor in terms of location, referrals, and accessibility. And then the cost, like the relative cost effectiveness. As mentioned, ketamine is always off-label in its uses in psychiatry, and it's, I have only seen like 1 or 2 cases where reimbursed is generally paid for out of pocket, and so those costs can range pretty notably depending on where you're getting it and the provider and the setting. And so it's one thing to take into consideration, whereas the esketamine is covered by most insurances because of its FDA-approved indications in psychiatry, but there are other embedded costs and difficulties there, so it just takes a individual look at those circumstances. And so wanted to kind of dovetail into getting a broad overview of what these treatment courses even look like and kind of what that process is like for receiving one of these medications. And so esketamine or Spravato is a much more like rigid structure, and it's available in 2 doses, 56 or 84 milligrams. Somebody gets 56 milligrams at their first treatment, and then at the second treatment can either stay there or go up to the 84 milligram dose based on response or tolerability. And it's kind of divided in these 2 phases of induction phase and maintenance phase. And so the induction phase is that first 4 weeks receiving it 2 times per week, and then if at that point at the end of 4 weeks there is an assessment of the utility and the response, and if it's something where there's antidepressant response is noted, then it can be continued to a lesser frequency, similar to a lot of the other interventional type treatments we use in psychiatry with ECT, TMS, IV ketamine. They all kind of have this initial acute phase and then a maintenance phase if you're seeing a response from it. So ketamine is quite different from Spravato in that it's available in these multiple different formulations, and the treatment course does kind of depend on the formulation. The IV or intravenous formulation is by far the most studied, best evidenced, and most frequent route of administration. So just highlighting that treatment course here. The ideal frequency and dosing of the IV ketamine is not formally established, but generally the standard practice is that people begin with an initial dose of 0.5 milligrams per kilogram infused over a 40-minute time frame, generally in a room with eye shades or music. Doesn't have to be that way. And then from there, on subsequent treatments, the dose can be flexible and go up to 1 milligram per kilogram, and at a frequency of 2 or 3 times per week. There's no difference in the efficacy or outcomes if you're receiving it twice per week or 3 times per week. It's just a logistics item. And then generally, it's you would like to aim for monitoring over 4 to 6, sometimes 4 to 8 treatments, and then at the end of that time kind of take a step back and pause and assess assess where things are, and if there's, say, if you're using depression rating scales, a benchmark of if you're not seeing a greater than or equal to 20% change from the baseline, you can kind of consider that a non-response and stop further treatments. But if so, then you can continue forward at a frequency that is defined with each individual person. And so kind of moving to some of the more BCH specific items here. So in our Center for Interventional Psychiatry, we're currently offering the IV ketamine treatments and at the Della Cava Family Medical Pavilion. And these are the first few steps, kind of pulled and adapted from the website. And so the referral is essentially, there's the need for referral from an outpatient psychiatric provider. This can be a MD, DO, a psychiatric nurse practitioner, but the first step is to receive a referral, and then that is processed, and then there is a subsequent next evaluation with a BCH specific psychiatric provider, such as myself or one of the others psychiatrists that are working in the Center for Interventional Psychiatry, just to reassess whether this is an appropriate fit, go over risks and benefits, and then make a decision and treatment plan from there. And following that, there will be further call and discussion with the CIP staff to discuss logistics, cost payment, scheduling, all those things, if that's going to be the plan going forward. I included a tiny little link to that part of the BCH website where it goes into a lot more depth, both on the IV ketamine treatments that we offer, as well as the other services like the ECT and the TMS. So I kind of just blasted through a lot of information, and so late in the afternoon, appreciate that, but if there are any questions, some time.
What's the efficacy or effectiveness of ketamine compared to antidepressants? I know that's a tough question, but maybe you can just give us a bullets.
Like in terms of
how effective is it? As effective, more effective than, let's say, a standard course of an SSRI?
Yeah, and the short answer is yes, and also because that depends on how many trials of an antidepressant one has had before, and the percent remission goes down with each subsequent trial of an antidepressant. So like the data from the STAR-D trial is around 1/3 of people respond to the initial course, and then it can go down from there. Whereas there's a lot more variable data from the ketamine because it's more gathered on the meta-analyses of these smaller trials, and smaller trials generally going to have larger effect sizes, and so for the short-term acute responses, I think more effective, but again, the issue lies in the duration, and that those antidepressant responses will last anywhere from a couple days to a couple weeks at most, and then the problem is finding ways to then maintain and sustain that response, whether it's maintenance ketamine treatments, psychotherapy, or just other ways to bolster that.
Hello. Do you know what the turnaround time is between getting a referral and actually the patient getting in for the consultation and starting treatment?
I do not have a solid answer for that, and that might.
We can get them in for an appointment within a week for sure. Yeah, so it's short.
Other questions? Oh.
It's not really a question. I just wanted to add, in terms of services, we do have the adjunctive psychotherapy to go along with the ketamine treatment. So we have a therapist that's dedicated for that, and so that is available to our patients as well.
Any more questions for Dr. Kromka? Oh, wait.
Or I guess maybe it's a little bit for